Chapter 21, Allergy and Anaphylaxis. All right, so this chapter will cover immunology, which is the recognition and management of shock and difficulty breathing related to anaphylactic reactions. We will be looking at the anatomy, physiology, pathophysiology, and assessment and management of hypersensitivity disorders and/or emergencies and anaphylactic reactions. Introduction. EMTs often respond to calls involving allergic reactions. Allergy-related emergencies may involve acute airway obstruction and cardiovascular collapse. You must be able to treat these life-threatening complications. You must be able to distinguish between the body's usual response to an allergen and an allergic reaction. Immunology is the study of the body's immune system. There are 5 categories of stimuli that may provoke an allergic reaction. The immune system protects the body from foreign substances and organisms. When a foreign substance invades the body initiates a series of responses to inactivate the invader. This is how the body becomes sensitized. When the body is sensitized, think of it as the body is recording the structure of the invader and creating antibodies in case it returns in the future. Now, pathophysiology. An allergic reaction is an exaggerated immune response to any substance, not caused directly by an outside stimuli, caused by the body's immune system, and the release of chemicals to combat stimulus, which includes histamines and leukotrienes. We're going to focus more on the histamine. When histamines and the leukotrienes are produced at a systemic level, specifically the histamine, it can cause issues with the airway and it can cause issues with circulation. So it can cause the airway to become irritated and constricted, and it can cause the blood vessels to dilate and become more permeable, which causes a drop in blood pressure. Some patients may not know what is causing their reaction, so you must recognize the signs and symptoms, maintain a high index of suspicion. An allergic reaction may be mild, local, or severe and systemic. Once it's severe and systemic, you now have anaphylaxis present. If it's mild and localized, antihistamine is fine for treatment. Anaphylaxis is an extreme, life-threatening allergic reaction. It involves multiple organ systems and can rapidly result in shock and death. And to your left, you will see a diagram that shows the signs and symptoms associated with each system. So the sequence of events in anaphylaxis, an antigen is introduced into the body, whether it was ingested, inhaled, absorbed, injected, it enters the body. An antigen antibody reaction is then activated at the level or surface of the mast cells. This results in chemical mediators being produced, and the chemical mediators is what is going to create the signs and symptoms that you see when the patient presents. Specific antibodies reacts with its corresponding antigen. Chemical mediators exert their effects on end organs. So with the lungs, the patient can have bronchoconstriction, vasoconstriction as a result of the chemical mediators. With the heart, they can have decreased cardiac output, decreased coronary flow. With the blood vessel, they can have vasodilation and leaky blood vessel. With the skin, they can have pruritus, which is that's not the itching, I believe that's swelling or something that looks like wheal. Urticaria is the fine bumps that cause the itching, and they can have edema. Now, 3 common signs of anaphylaxis. 3 common signs. 1, urticaria or hives. Small areas of generalized itching or burning that appear as multiple small raised areas on the skin. That's urticaria or hives. So that's one of the common signs. 2, angioedema or airway swelling or swelling. And they show a nice picture of that. So that's a patient with angioedema. There's a particular blood pressure medication that can cause this angioedema. What's it called again? ACE inhibitors. So patients that are on ACE inhibitors can also develop this reaction, angioedema. So urticaria, angioedema, wheezing, high-pitched whistling breath on expiration. As you can see now, a lot of conditions can cause wheezing. You may also note stridor on inspiration due to upper airway narrowing, hypotension due to vasodilation and increased capillary permeability, nausea, vomiting, and abdominal cramps. Common allergies. Food may take more than 30 minutes to appear. Shellfish, nuts. Medication, antibiotics, example penicillin, non-steroidal anti-inflammatory drugs or NSAIDs or NSAIDs. Medication, if medication is injected, the reaction may be immediate and severe. Reactions to oral medications may take more than 30 minutes to appear, but can also be very severe. For plants, dust, pollens, and other plant materials, ragweed, ryegrass, maple, and oak. For chemicals, makeup, soap, and hair dye, latex is of particular concern to healthcare providers, but in this day and age, latex gloves are not used in the pre-hospital setting in first world systems. Insect bites and stings. Envenomation, the process of an insect injecting its venom. The reaction can be localized or it may be severe and systemic. Approximately 2 million Americans are allergic to venom of bees, wasps, and hornets. I don't think we have that issue here much in Jamaica. Allergic reactions to insect stings can cause at least allergic reactions to insect stings cause at least 62 deaths per year in the United States. In about half of these deaths, the victim had never experienced a reaction to prior stings. The stinging organ of most insects is a small hollow spine projecting from the abdomen. The honeybees cannot withdraw their stinger. Wasps and hornets can sting multiple times. Some ants, especially the fire ants, strike repeatedly. All right. Now, signs and symptoms that you should look for insect stings. Sudden pain, swelling, localized heat, urticaria, redness in light-skinned individuals, itching, and a wheal. In severe anaphylactic cases, patient may experience stridor, bronchospasm and wheezing, chest tightness, coughing, dyspnea, anxiety, gastrointestinal problems, hypertension. Patients may occasionally experience respiratory failure, and if they're at that point, they're in significant trouble. If untreated, anaphylactic reaction can proceed rapidly to death. More than 2/3 of patients who die of anaphylaxis do so within the first 30 minutes. Very important. All right, now let's look at the patient assessment in immunologic emergency. Perform your scene size up, scene safety. The patient's environment or recent activity may indicate the source of the reaction, sting or bite, food allergy, new medication regimen. Be mindful of other potential causes of respiratory distress. Traumatic injury may also be present. Follow standard precautions with a minimum of gloves and eye protection. Consider the need for additional resources such as ALS personnel. After you have completed your scene size up, next phase of your assessment is your primary assessment. Quickly identify and treat any immediate or potential life threats. Form a general impression of the patient and the environment. May present as a respiratory or cardiovascular distress in the form of shock. Patients often appear very anxious. Call for ALS backup if available. Look for medical identification tag. Assess airway and breathing. Anaphylaxis can cause rapid swelling of the upper airway. You have only a few minutes to assess airway and provide life-saving measures. Work quickly to determine the severity of the symptoms. Time is important now. Quickly assess for increased work of breathing, the use of accessory muscles, head bobbing, tripod position, nasal flaring, abnormal breath sounds. Assist the patient into the high Fowler position to maximize ventilation. If signs of shock, place the patient in supine position. Do not hesitate to initiate high flow oxygen. In severe situation, assist using a bag mask device with oxygen attached. For circulation, may present with hypotension, that's low blood pressure. Palpate for the presence and quality of a radial pulse if they are responsive. Assess for rapid pulse rate, cool, cyanotic, or red, moist skin, delayed capillary refill, may indicate hypoperfusion, shock. Once you have completed your ABCs, what is your patient's GCS? You can check the pupils if you want at that point. Do you need to do a rapid scan? Do you need to focus on the system involved? System involved would be respiratory, cardiovascular, and also immune system. Is it a patient that you need to stay and play with, or is it a load and go? These questions need to be answered. Treat for shock. Definitive treatment for anaphylactic shock is epinephrine. That's your first line treatment. If you suspect anaphylaxis, do not give the patient DPH first. Always provide prompt transport for any patient who may be having an allergic reaction. If the patient does not exhibit severe symptoms, consider continuing the assessment. Err on the side of emergency transport. After you have packaged your patient and you're ready for transport, once the patient is talking, you want a history. Be mindful of how you ask a question. You might want to limit your open-ended question, especially if they're having significant difficulty breathing. You might want to limit your question into yes or no questions. Identify associated signs and symptoms. All right, now this is a nice chart that outlines specific signs and symptoms associated with specific systems when an allergic reaction is occurring. Give it a read. Obtain a sample history, excuse me. Sorry about that. All right. Obtain a sample history. If possible, ask the following questions. Have any interventions already been completed? Has the patient experienced a severe allergic reaction in the past? Be alert for any statements regarding ingestion of foods that cause allergic reaction. Ask about gastrointestinal complaints, nausea, vomiting. After your history, next phase is a secondary assessment. Physical examination, systemic head to toe, or focused assessment. Decide whichever is appropriate. Auscultate for abnormal breath sounds, wheezing or stridor, anterior and posterior points. Inspect the skin for swelling, rashes, or urticaria. For the physical examination continued, assess your baseline vital signs, and at this point, the purpose of the vitals is to identify trends. Is our patient now trending up or trending down based on the initial findings and what we're seeing? No. So pulse and respiratory rates, blood pressure, pupillary response, oxygen saturation. Skin signs may be unreliable. Use your monitoring devices. Pulse oximetry can be a useful method to assess the patient's perfusion status. Decision to apply oxygen should be based on airway patency, work of breathing, abnormal lung sound, pulse oximetry on room air. After your secondary assessment, reassessment. Repeat the primary assessment, reassess the patient's vital signs, and repeat the focused physical exam. If the patient is unstable, reassess every 5 minutes. Patient is stable, every 15 minutes. Watch for signs of shock. Interventions. Determine the severity of the reaction. Mild reactions require supportive care and monitoring. If you suspect anaphylaxis, this patient will require epinephrine and ventilatory support. Transport to a medical facility. Recheck your interventions. Communication and documentation also occurs in the reassessment phase. Documentation should include signs and symptoms, reason why you chose to provide the care you did, patient's response to the treatment. Now, emergency medical care for immunologic emergencies. If the patient appears to be having a severe allergic reaction or anaphylactic reaction, administer BLS, provide prompt transport to the hospital. If a stinger is present, scrape the skin with the edge of a sharp, stiff object such as a credit card. Do not use tweezers or forceps. Wash the area with soap or antiseptic agent. Remove any jewelry from the area. Position the injection site below the heart. Apply ice or cold packs. Be alert for signs of airway swelling and other signs of anaphylaxis. Place the patient in a supine position and give oxygen as needed. Monitor the patient's vital signs. Epinephrine. Epinephrine mimics the sympathetic fight or flight response. It causes the blood vessels to constrict, and it reverses vasodilation and hypotension. So the two main problems in anaphylactic reaction, epinephrine reverses these issues. It increases cardiac contractility and relieves bronchospasm, rapidly reverse the effects of anaphylaxis. Epinephrine is prescribed by a physician and comes pre-dose in an epinephrine injector or EpiPen. Your EMS service may or may not allow you to assist the patient in the administration of epinephrine. Refer to local protocols or consult medical control. All kits should contain a prepared auto-injectable syringe of epinephrine. And most services don't carry the EpiPen anymore. The medication actually has to be pulled up using a syringe because the EpiPen is just too expensive. Adult EpiPen delivers 0.3 milligrams to 0.5 milligrams of epinephrine intramuscular. The infant or child system delivers 0.15 to 0.3 milligrams of epi. The adult administration is lateral aspect of the thigh. Pediatric administration is medial aspect of the thigh. Side effects of epinephrine: high blood pressure, increased pulse rate, anxiety, cardiac arrhythmias, pallor, dizziness, chest pain, headache, nausea, vomiting. Do not give epinephrine to patients without signs of respiratory compromise or hypertension. Very important slide. Those who do not meet the criteria for a diagnosis of anaphylaxis. And that would be the end of this chapter. A lot of this